doing a chest x-ray, and we're going to start with the PA projection. The PA projection means that the central ray is going to enter the posterior part of the patient, and the anterior part of the patient is going to be turned towards the image receptor, which means that the coronal plane of the body is parallel with the image receptor. So the first thing we're going to do is ask our patient, any possibility of being pregnant? No, there is. And we're going to shield our patient. Too high, some people have their costophrenic angles quite low, so you don't want to risk cutting that off. Okay. And we're going to choose our right size cassette, which in this case will be, for most people, you can use a 14 by 17 lengthwise. Some people who have short trunks and larger crosswise, you may turn the cassette crosswise because you want to make sure that you get both the apices and the costophrenic angles, and that you don't cut out any body part. Okay? Roll the shoulders in. The reason why you want them to roll the shoulders is because you want to get the scapulas out of the way of the lungs for better visualization of the lungs. Okay? You want them to go real close to the IR, because the shorter the distance in between the body part and the IR, the better visualization and better detail you get. Okay? Your SID for a PA of the chest is 72 inches. You want to place the IR about 1.5 to 2 inches above the shoulders. Because the reason for that is because you're going to want to take this x-ray with the patient in deep inspiration, which means that the shoulders are going to be a little higher than as at rest. All right, next on our routine views of the chest, besides the PA, we should do a lateral. For all purposes of this video, we're going to assume the patient has been shielded and that markers have been placed. We are going to place our patient with the left side, left lateral side closest to the IR. We're going to ask our patient to bring their hands up. They can, if they want, rest their hands on their head. Remember to ask them to bring their elbows forward so that it doesn't create a space in between the patient and the IR. Okay? Have them come close to the IR and still standing straight though. A lot of patients will have a tendency to kind of lean. You don't want that because you don't want any distortions, okay? If you already did the PA projection of this patient, the alignment of the cassette should be, you shouldn't have to change it from the PA to the lateral position, okay? So now, everything is lined up, our cassette and our central ray. You want to make sure that the patient is perpendicular to the IR. So you're gonna, it helps if you put your hand perpendicular to the IR and make sure that her shoulder blades are perpendicular also, okay? You want the central ray to come right underneath her axilla and right down the middle of her body, okay?
Okay.
All right. You would have put your left marker where it does not interfere with the body part that you're trying to x-ray. Okay? You would have the patient take a deep breath in, take a big breath out, empty completely, take a big breath in, and you would shoot the picture. A special view or projection of the chest called the lordotic projection. And what we're going to do, the goal of this is to actually see the apices of the lungs without any superimposition from the clavicles. So we're going to want to shoot at an angle, basically. Do a step forward about 8 to 12 inches away from the IR, and we're going to have them lean back until their shoulders touch the IR. Okay, they're going to put their hands on their hips. Same way, it helps stabilize. And we're going to direct the central ray about mid sternum. Okay, we're going to need to center her. Needs to go right alongside the sternum, so we're going to bring her this way a little bit, about mid-sternum, and of course now we have to adjust the IR so that everything is centered. Okay, make sure the patient is very well centered, and there's your lordotic. You should get a free view of the apices of the lungs without any superimposition from the clavicles. Pause the video and review the procedure before continuing. Make sure that you can recall the name of the projection, the SID, the patient position, specific positioning for the selected part of anatomy on the image receptor. Note any specified angles or of the part that you're positioning or reference to a body plane as you go along. We are now going on with our lower extremity and our tib-fib projection. There are several considerations to have when you x-ray a long bone like the tib-fib is. Every time you want to you have to do an x-ray of a long bone, you want to always include both joints the bone attaches to. So somehow you're going to have to show the radiologist the ankle joint and the knee joint. For most people, a 14 by 17 cassette, it is not long enough to accommodate both joints in the same film. So we have to kind of catty corner our cassette in hopes that we can accommodate both joints. In the case that the patient's leg is too big, and even using a catty corner cassette, you're still missing cutting a part of interest, you can do two projections. You would do a projection where you would get the ankle, and then another projection where you would get the knee part, okay? But you never want to miss the part of interest. So, for this particular patient, we're going to have her with an extended leg, extended knee, and we're going to have her bring her toes towards herself in a dorsiplantar fashion in order to get all the open spaces. The CR is going to be midway of the tib fib, and of course you're going to have to open your collimation to include both the ankle and the knee joint, which in this case is possible because our model is quite petite. Next routine projection for the tib fib is the lateral, and we're going to ask our patient to lay on her side towards the affected side, or with the affected site closest to the IR. And same concept, you want both the joints in, so you're going to have her bend her knee about 45 degrees. It's a little too much. There. Okay. You want to make sure that if she brings this one back to make a perfect 90-degree angle. Okay. Make sure that this knee is not going to obstruct the affected knee view. Again, okay, very good. And the CR midway through the tib fib. For the projections of the knee, I have some special considerations to tell you about. If the knee is larger than 10 centimeters in diameter, in thickness, this projection should be done with the grid, so with the cassette on the bucky. If the knee is like hers, pretty small, we measured hers. And we measured her knee, and her knee comes to about 10.5 centimeters. We were measuring in inches. 10.5 centimeters, which is usually the cutoff is about 12 centimeters. Body part, anything thicker than 12 centimeters should require a grid. So in this case, we did tabletop because hers was still under the. There's also some supplemental views of the knee, of the space, the joint spaces that you can look at in your book and study through there. Our next view that we're going to actually demonstrate is the most common supplemental view, which is the sunrise view. And there's two ways to do the sunrise view, which we're going to demonstrate next. So for the sunrise view of the knee, we're going to have the patient in a recumbent position, and we're going to have her flex her knee on the affected side about 80 degrees between the femur and the tibia, or the tib fib. We're going to angulate the CR about 15 to 20 degrees cephalad, and we're going to center the central ray in the inferior margin of the patella. Of course, the inferior margin now is going to look like it's superior if we were looking at it this way, but this is the distal part of the inferior member, so that would be distal. Okay? And of course, we're going to collimate. Again, this projection can be done tabletop. We've already determined that her knee is small enough. If she had a bigger than 12 centimeters knee, the cassette would be in the bucky. If your patient cannot hold their leg in this position, you can use a belt or a strap of some kind, just like we did before for the calcaneus, and wrap it around here and come over her shoulder and have her hold it in case for some reason due to pain or other limitations she could not hold her knee flexed this way. And that's your sunrise, one of your sunrise projections. In case your patient could not lay prone and bend their knee on the previous projection, this is an alternative method of doing a sunrise. And where the patient is sitting, it's a little more comfortable for some patients. You do have to most likely bring your tube outside of the range of the table, because you're going to have to lower it more than what the table usually allows. So it kind of depends on how your X-ray room is built, whether or not you're going to be able to do this. Still, your knees bent at about a 90 degree angle between the femur and the tib fib. The patient is actually the one holding the cassette, and you have about a 15 to 20 degree angulation on the tube, and that's cephalid towards the head. And you want the CR to be in the inferior margin of the patella. Okay? And you have to make sure your patients will have the tendency to let their knee drop to the outside laterally, so you have to make sure that you have them keep still. Pause the video and review the procedure before continuing. We are now going to proceed with the examination of the calcaneus, or the heel. And for the calcaneus routine examination, we have two views: axial or plantar-dorsal, and lateral. Okay? As you know, the calcaneus is your heel bone. And axial, we want to see the heel bone through plantar-dorsal. So the central ray entering the plantar aspect of the heel and coming out the dorsal part. For that, of course, we're going to need some angulation and some participation from the patient if possible. It will help make the projection and the picture a little more detailed. Okay? So, you're going to angle the tube, angle the CR at a 40 degrees cephalid, or towards the head. Kind of hard for a patient to flex their foot that much. We're going to ask the patient to bring their toes towards them as much as possible. You can use a bandage of some kind, a belt, doesn't really matter, as long as it helps. And you have the central ray right on the calcaneus, on the mid aspect of the calcaneus. Still with the plantar surface of the foot touching the table. The CR is going to have an angulation of 10 degrees towards the heel, or posteriorly. Reason for that is because, as you know, the heel portion of the foot is thicker than the toe portion of the foot, at least for most people. So you want to compensate that, and you also want to be able to see all the open spaces in between on the joints. And because it makes angle, you have to angle the tube in order to enter the spaces in between the joints, which is what you want to visualize. Okay? Central ray is not where it's supposed to be, which is on the third metatarsal. Position of the foot. We're going to ask our patient to lay on their side towards the affected side. Okay? And we're going to have the patient bring the opposite knee up like this. Okay? And we're gonna make sure their foot is completely at a perpendicular 90-degree angle where they are. You may have to rotate your tube in order to make an aesthetical pleasing radiograph. Okay, again, your CR is going to be about the base of the metatarsals, so in the middle of the foot. You want to make sure that your foot is at a 90-degree angle as much as possible, and you want to make sure that you don't cut the toes. Okay, so you're going to be careful with the collimation. Okay. Continuing with the study of the foot, our next position for routine visualization of the foot is the oblique position. Still SID at 40. Only difference now is you do not have an angulation anymore. Okay, so we're going to roll it back to perpendicular and bring it back to the third metatarsal, and we're going to have the patient roll their foot medially in about 45 degrees. Okay. Pause the video and review the procedure before continuing. Okay, we're going to demonstrate shoulder studies. We're going to use for most shoulders, we're going to use a 10 by 12 cassette. So we're going to place 10 by 12, and I actually like to put it crosswise, because if you think about it and your shoulder view, you're going to get you want to get the scapula, the clavicle, the whole shoulder girdle, and a little bit of the probably 1/3 humerus. So you will get more if you crosswise the cassette, as if you do it this way lengthwise, you might cut some part that it's important, so you definitely want to use it lengthwise. Okay, so we're going to place your cassette 10 by 12 crosswise. Okay, your SID is going to be 40 for the shoulder, and no rotation on the central ray. So the central ray is going to be perpendicular to the IR. Okay, we're going to place the IR, so remember we want to see the shoulder all the way from here to about there. Okay, so you're going to want the film to be slightly on top of the shoulder, probably about 1 inch, because you're going to have the patient hold their breath. In the case that the patient holds their breath right after inspiration, as you know, with inspiration your shoulders level is going to come up a little, so you want to make sure you don't cut anything out. So about that much, about 1 inch above the shoulder will be okay. 1.5 inches, not going to hurt, as long as you don't cut the body of interest. You're going to want a little bit of the humerus, proximal 1/3 of humerus at least. So here you go. If you kind of try to figure out, here you are, you have about the proximal 1/3 of the humerus right here. Okay, so that should be okay. So you're going to center ray to your cassette, which is almost perfect. There you go. Okay. And now you're going to position your patient for the correct shoulder. In this case, we're going to be doing the right shoulder. So we're going to ask our patient to slide that way a little. Very good. Okay. For the shoulder, of course, you would want the patient to remove the bra if it was a wound. So you definitely want to make sure that your patient doesn't have anything here. No bra, straps. Of course, she would be shielded, as we already said in the beginning of this film. The two routine positions for the shoulder are internal rotation and external rotation. Okay, so internal rotation, you are going to abduct the arm slightly and have the patient bring their hand to their hip. So the palm of the hand against the hip. Okay, and you're going to try to keep them as straight as possible, looking straight. Okay, now the central ray, you're going to want it, if you can't visualize very well, if you can't remember very well, what you want to know, what you want to see is the space in between the head of the humerus and the scapular girdle, or shoulder girdle per se. So if you can envision this joint, you have a ball and socket type of joint, okay? And what the doctor is going to be looking at is the space Okay, go ahead. All right, so for your external rotation, your patient's going to be in the exact same position. Everything is going to be the exact same thing, except that the arm position of the patient is going to abduct and do external rotation, which means bring the palm forward, okay? Same exact everything, all right? Sometimes the doctor is going to want to make real sure that the integrity of the joint is preserved. So they're going to want to see that the space, not only the space in between the head of the humerus and the girdle is intact, but also that there are no deviations, there's nothing inside that joint that could be impeding that joint in some way. So what they want to see is they want to see almost the complete space from one end to the other. So we use a projection called an AP oblique. And basically, you're going to do the exact same thing as you did for the AP of the shoulder, but you're going to turn the patient about 35 to 45 degrees with the affected shoulder closest to the IR, okay? You're going to try the central ray to be directly on that space, as I mentioned previously, where the head of the humerus starts its connection with the shoulder girdle. So right there is where you're going to want your CR, okay? And in this way, because the joint is angled in this way, you basically opened up the space so that the doctor can see right through it, okay? And you'll be able to determine the integrity of the joint. So this will be your AP axial of the shoulder. Occasionally, your doctor may request another projection called a PA oblique view, which is also better known as a Y view, okay? In the Y view, we want to see that the scapula is intact and in good position in relation to the shoulder. Your affected side closest to the IR, in this case, we're going to say that her affected side is the left side, okay? So your affected side closest to the IR, you're going to still be at 40 SID. For this projection, you may use the same 10 by 12 cassette, but in this case, I would not use it crosswise, I would use it lengthwise. The view that you're going to be seeing is a view in this way of the scapula, and it's going to show up almost as a Y, and so you know it's a lengthwise image, okay, which is why we call it the Y view. It's going to appear as a Y. You're going to want the top of your IR to be about 1.5 to 2 inches above the shoulder. So I can bring this down a little now to there, okay? And if you are not sure if you got this without cutting anything, just bring your hand down to the end of the scapula in the patient and make sure that your cassette is within that area, which it is in this case, okay? So your CR is centered to the cassette. And what you're going to do is you're going to keep your patient just straight, standing up straight, but you're going to turn her oblique. Go ahead and step forward. There you go. Not so much. About 35 to 45 degrees, okay? So basically what you want, if you put your fingers through here and kind of feel her scapula, you want the CR to go kind of in that space where the scapula kind of juts out. Sometimes jut out, you can have your patient bend her elbow a little bit, okay, to kind of help it jut out a little and kind of bring the interior portion of the shoulder as close to the IR as possible, okay? And there will be your wide view. You probably need to colorment this a little, to about that, okay? Okay, we're moving on to the clavicle. There are several considerations to have when you are doing a clavicle study. In a lot of cases, if not most cases, the doctor is going to want a comparison view. Okay, so a lot of the times, if you do one clavicle on one side, you'll have to do another clavicle on the other side. In some cases, techs would use, if the doctor wants a complete view of the the entire both sides uninterrupted, you could use a 14 by 17 crosswise, and hopefully would get most of everything. But let's suppose the doctor only wants to see the affected side. I would use 10 by 12. Again, you want it lengthwise, however, because you want to catch everything from the end of the distal or external part of the clavicle all the way to where it connects to the sternum. Okay, so you know a 10 by 12 crosswise would be perfect. Okay, so you're going to want to bring the top of the cassette about 2 inches above the shoulder. Okay? In this case, you want the clavicle as close as possible to the middle of the cassette, and since the clavicle is a long, thin, long-wise or crosswise bone, you about want the middle ray across it. Okay, so we're gonna central your central ray. As you can tell, it's pretty much aligned with her clavicle already. Okay, so your central ray is going to want it midpoint in the middle of the clavicle. Okay, so we're going to bring our patient to have a step that way. Very good. That was maybe a little too much. Just got this way a little. Right there. Okay. All right. So here's the middle of my scapula. I'm going to open it crosswise. And as you can tell by the shadow, there's her sternum, so I definitely get her connection with the sternum, and here all the way the connection with the humerus. So I get all her clavicle. Make sure that your right marker is not going to be in front of any of the body parts of interest. Okay. Now, because the clavicle is a rounded, 3-dimensional bone like all the other bones, we sometimes need to see it in different perspectives. Of course, I'm going to back up a little. You can have this study done whether standing or laying down on the table. It would be the same thing. If you're going to do AP projection or AP axial, you're going to want to angle the tube 15 degrees, about 15 degrees cephalad towards the head. So let's roll our tube 15 degrees. And we're going to bring it to the clavicle, and we're going to have to compensate here. And you have your axial, your PA axial of the right clavicle. Okay? If for detail purposes, of course, you want the body part of interest as close as possible to the IR, the image receptor. So you can do it if you turn your patient completely around to the side, still keeping the right clavicle closest to the IR. You're going to stay straight now. Straighten out. Okay? Just try to bring it as close as possible. Of course, sometimes our patients are well developed, and it doesn't go as close as you want it to. But in this case, what you're going to do is you're going to angle 15 degrees caudate. Okay, so it's like you're picking at it from the top. Okay, and of course then you will have to adjust. You can imagine that your clavicle is, up there, and you're going to have to adjust your film that is not there. Okay. Straight. And this way, your clavicle is a little closer to the IR and therefore provide a little more detail. So just remember, if it's a PA projection, you're going to angle 15 degrees caudate. If it's an AP projection, you're going to angle 15 degrees cephalad. We're moving on to the scapula. As you know, the scapula is that wing bone that people have back there. If you remember the shape of your scapula is kind of like on the long direction, per se. So you're going to use 10 by 12 lengthwise. Okay? It's still done at 40 inches SID. And we have two main positions that we use, or two main projections. First one is an AB projection, where the patient is going to be standing straight with the back closest to the IR, or the scapula closest to the IR. And what we're going to do is we're going to try to bring the scapula kind of out a little so that you can see it better if it's away from, as possible, from the lungs and the other body structures. So we're going to set up our CR straight to the middle of the scapula. If you have a hard time trying to visualize where the scapula is, bring your patient away from the board a little and kind of bring your hand and feel for the scapula, okay? And you can feel it kind of triangles to the bottom. So feel it around and kind of find its midway point, and then try to bring it around to the front of the body with your eyes, okay? Middle of your scapula is probably going to be a point midway between the shoulder, the top of the shoulder, and the nipple line. Okay, so your CR is going to want to be about there. Okay, bring your patient back down straight and bring your CR down to about where you figured out you have your mid scapula. Adjust your film. So you are centered, and now all you have to do is adjust your patient. And as you can tell, your scapula is not in the middle, it's closest to the side. In this case, we're doing the right scapula. So you're going to bring your patient, there you go, still straight, okay? Right around the middle, midway through the clavicle, and midway between the clavicle and the breast line, and you'll have your scapula. Okay? Now, in order to move the scapula and move everything in a way that we can really see it, we're going to abduct the patient's arm about 90 degrees and flex the elbow with the palm of the hand to the front. We call this the I swear, allegiance, whatever you want to call it. But if you want to think about it, you swear on the Bible when you're in a court, when you put your right arm up, that's the position that you use. Your second position that you need to do with your scapula is a lateral position. And as you can imagine, it's kind of difficult to get a lateral view of your scapula. It's kind of similar to the wide view. In order to see the lateral of the scapular in a lateral view, you're actually going to have to oblique your patient a little to where the scapula is actually towards the CR. Okay? There are two ways, depending on your patient and how difficult it is to position their arm in one way or another. There are two ways in which you can try to bring the scapula out to kind of see it laterally. One way is to have the patient, if they can, bring their arm behind their back and kind of bend their, flex their elbow. And as you can tell, that kind of jots out the scapula, okay? So that's what you're going to do. You're going to position your patient to where the CR is going to come in right where the scapula jots out, where you can feel the scapula jotting out, okay? Make sure your patient is, that you get everything. Okay, and this is what you're going to get in your picture, a view of the lateral of the scapula. If for some reason your patient cannot bring their arm down, you can try having the patient bring their arm up in the front. Kind of like bring their hand, let me see, across their chest. Pause the video and review the procedure before continuing. Today we're going to review projections of the hand, the fingers, and the wrist. For projections of the fingers are usually done together with the hand. However, under certain circumstances, the doctor may want just a projection of the finger in question or fingers in question. So you're going to have to follow the protocol of the place where you work. In case your doctor wants solely the finger in question, you're going to have to include the entire finger and the metacarpal to which is attached, at least. In a lot of other places, you would have to present a PA projection of the hand and then a lateral and oblique of the finger of interest. So I'm going to demonstrate a general projection of the fingers as a whole, and then I will demonstrate a projection of the thumb as finger of interest. Okay? So if your doctor asks you for a projection of all fingers, okay, your SID is going to be at 40 degrees. Your patient can sit down. These projections don't require a bucky, so they can all be done on tabletop. Smallest cassette, which will include the part of interest, usually a 8 by 10, and there is no angulation for either of these projections. Projection of the fingers. You're going to want say you're doing an AP projection of the middle finger. We're going to isolate the middle finger as the finger of interest, for example. Okay, so you're going to put the central ray alongside the long axis of the middle finger, and you're going to collimate to it. So you collimate to the entire finger. You want to make sure you get the entire finger plus the metacarpal that it's attached to. Okay. You mark the side. This is the right hand. So this would be the projection for a PA of the middle finger. To do, if you wanted to do all the fingers, you would just simply open your collimation to include all fingers, and you pretty much would be doing a hand, a PA of the hand, which is why in most cases when a finger is requested, we just end up doing the whole hand, because you have to include, if it's all the fingers that you're looking for as interest, you have to include the metacarpal, so you might as well just do the entire hand. Okay? If it's for a finger individually, the central ray is going to be right in the medial joint of the finger, right in the middle over the knuckles. If you're doing all the fingers at the same time, you're going to have the hand come up a little, and you're going to have the same central ray as for the hand, which is the base of the third metacarpal. Okay? For an oblique projection. So actually, going back a little, this is also a PA projection for the hand. So whether you're doing a hand or fingers, you actually are using the same projection. For oblique projection, if you're doing an oblique projection of the entire hand, you can do it in two ways. You can either have your patient put their hand on the side like this, and then just relax his fingers and let them fall until they touch the cassette, and just kind of help them spread their fingers along. Okay? Central ray still in the same spot. You want the hand of about 45 degrees, so this angle here will be at a 45 degree with the cassette. Okay? If you wanted to do just one finger, you would simply move the central ray to the middle of that finger, so if we were doing this one, and you would column A to that particular finger. Okay? And just make sure that you would get the entire finger. Okay? So that is your oblique projection. Your lateral projection, which would be your next one. If you're doing the entire hand, there is two ways to do a lateral projection. You can either put the hand completely on the lateral side and bring your thumb straight down. That's the traditional lateral projection. However, as you can probably imagine, this position of the hand is not very demonstrative, because you have all the fingers superimposed. So we tend to either use a sponge that's going to help us separate the fingers, or you're going to have your patient joint their thumb and their first digit, and then you're going to have them fan the digits around, and therefore you're going to get a lateral view of each finger separately. You have to make sure that the hand is still at a 90-degree angle with the cassette. So you want to make sure that their wrist per se is still in a lateral position. Okay, that would be it. If you were going to use the I personally very rarely do I use this. If anything, if I was going to use this, would be for an oblique, because I don't believe that this gives you a true lateral of the fingers. Okay, so I would use that aid for an oblique, maybe of the hand. Okay. So the one digit that is different than all the others is your thumb. Because of this anatomical position, you're going to have to modify the positioning a little bit to get the true projections that you want. So let's use this one now. Okay. So when you have the hand on a PA position, if you notice, your thumb is actually at a 45-degree angle with the cassette. So basically, that's your oblique position for the thumb. So if you want to do an oblique of the thumb, you basically put your hand in a PA position. And again, you can collimate solely through the thumb if you want to isolate it from the rest of the hand, or if you're doing the entire hand, that gives you the oblique position of the thumb. For a thumb to be on a lateral position, a true lateral position of the thumb, what you're going to do is you're going to have your patient close up, fist up your hand, and just bring it like that. Okay, this is a little not so. Okay, so now your thumb is in a true lateral position. Okay. If your patient cannot make a fist, they can still open up your hand. Okay? Just bring their hand up like that and just make sure that you the whole time. You cannot do a lateral of the thumb and the whole hand at the same time. Okay? Because there's no way to accomplish both things at the same time. Now, so we did the lateral of the thumb, the oblique of the thumb. To do AP of the thumb, or a PA actually, you can do a PA of the thumb, which you can actually do this way. Okay. Now this projection is going to give you a little bit of distortion, amplification, because you have a distance between the image receptor and the body part. If you don't want that, you want something that is really, really with the most detail possible, what you're going to have to do is you're going to have your patient turn their hand around and place the other fingers out of the way. So in this case, you're having an AP of the thumb instead of a PA of the thumb, but it's still going to give you a good visualization of the spaces in between the joints and everything that you need to do. Okay? All right. For most wrists, an 8x10 size cassette is just fine. The thing that is really important with the wrist is that you maintain the alignment between the forearm and the hand. So you're going to have to bring your patient towards me a little, very good, to where too much, right there, okay, to where the wrist and the hand are aligned. And you're going to do this right there. Oops. And you're going to put the central ray right in the middle of the wrist. Okay. Make a fist. Okay. The reason why you have your patient make a fist is because when you put your hand down flat, there is a little space due to the anatomical way of the hand and wrist. There's a little space you can almost put your finger through, which means that your wrist is not 100% in contact with the image receptor. So there may be a little bit of magnification due to that. However, if you make a fist, your wrist will immediately go down, and there's no way you can put anything under there. So that's the position where your wrist is to do the hand. So go ahead, open your hand, bring your fingers, touch these two fingers together, and let them fall on the cassette. Okay? You have a perfect oblique position of the wrist with a 45-degree angle to the image receptor. for the best contact, 100% contact with the image receptor. So you want to get a little bit of the hand, at least the metacarpals, and a little more of the forearm, not just, don't call and make too much, because the structures on either side of the joint need to be visible, okay? And pretty much from that is really easy. The oblique position of the wrist, you accomplish it the exact same way as you do the hand. So go ahead, open your hand, bring your fingers, touch these two fingers together and let them fall on the cassette. Okay? You have a perfect oblique position of the wrist with a 45-degree angle to the image receptor. For the lateral of the wrist, you're going to ask your patient to stand up and kind of lean down, and you're going to place their forearm at an even 90 degrees to the image receptor. The reason why we ask them to stand up is because it's difficult to align your forearm bones when you're sitting down. There's some rotation of the bones when you're doing this sitting down. So it is better to doing with a 90-degree angle of the elbow. It makes for a more true lateral of the wrist. So that's your lateral of the wrist. There is, you can go ahead and sit down again. There is a specialty view of the wrist that is very common. You're most likely going to encounter and talk about it, called the navicular. Okay? The navicular is a bone right in here that very often gets broken. So a lot of times we need to see it, or the doctor needs to see it a little better visualized than other bones. And as you know, all the carpal bones here are kind of like almost on top of each other type. It's kind of hard to distinguish them sometimes. So there's a view that we do called the navicular view that kind of isolates the navicular a little bit. And basically what you do is you put your hand or your wrist in the PA position, and you hold the thumb in the same spot, and you have the patient move all their fingers out. Okay? And this opens up the space here and brings the navicular out on the resulting X-ray. Alright, I hope this video was helpful. A lot of people, it's easier for them to memorize things that they see. I have some recommendations as far as preparing for the state board exam. When you are studying the different projections, make flashcards of each projection, and in each projection, make sure that you study very well what anatomy parts are viewed in each of the projections. A lot of times it is more important to know, if I want to see a certain bone, what view will it be the best view in order to actually, or which projection is going to be the best projection for me to view a certain bone. Most times the questions that come on the state board will have to do with the structures that are seen in each projection, so that's really important. Some tricks are easy, SID is going to be either 40 or 70. Anything that you do on tabletop is going to be 40. Chest is about the only thing you have to consider at 72 inches. So, keep that in mind. Don't waste too much time with that. angulations, try to go through all the projections and isolate the ones that have angulations and memorize that and remember those. There's not a lot, I believe, actually, of all the projections, chest and extremities. The only angulation you're going to have to worry about is on the apical view of the chest. So don't worry too much about angulations. I would also not spend a lot of time in the image receptor size. In reality, if you have a question about image receptor size, just think of whatever you use has to be able to accommodate the entire body part that you're trying to get. So, you know, if it's a hand, probably an 8x4 will do. If it's a chest, you're going to need the biggest one you can get, or an abdomen, which you're not even really, concerned with right now. Femur, for example, you're going to want the biggest IR. So if you don't spend a lot of time trying to memorize stuff that you can rationalize about. So the most important things are really the structures, where your central ray, what anatomical structure your central ray is supposed to be at, and for each projection, and what are the anatomical structures viewed with each projection. I would really concentrate on those two things. And before you know it, it'll all come to you without even thinking. Good luck.